So, welcome to another episode of the PML podcast, specifically for patients as well as practitioners who are interested in SI joint dysfunction management. There are multiple approaches now that have been FDA approved that are very beneficial to our patients. I am the inventor and founder of the PML technique. This was done in collaboration with SI Bone in California. I'm the inventor and founder of the PML Masterclass course, which is a course available both online platform as well as live hands-on surgical demonstration of the PML technique. The uniqueness of this is actually we get to teach both the conventional technique and the PML technique. My last live demonstration that we did last week was about 2 hours. We were able to demonstrate in surgery using cadaveric demonstration the conventional lateral to medial technique as well as the new revolutionary posterior medial to lateral technique. This technique is FDA approved, has been published in the Journal of Clinical Spine Surgery by me. Again, if you don't know me, my name is Dr. Baba Jide Ogunsende. I'm a Harvard trained, fellowship trained spine surgeon, as well as a primary orthopedic surgeon. I've done over 2,000 SI fusions. I've done probably over 15 to 1,600 PML screws, as well as over 1,000 SI fusions in the PML technique. We have done so many surgeries in this with this technique, and have so many testimonies, both oral testimonies, video testimonies, written testimonies that we will share with everyone as the time goes by. I want to thank everyone that has been supporting me on this quest. All the real supporters, even the people that didn't support me. I hope eventually you will understand that sometimes the train that has left the station cannot be stopped. So you either join the train or you get left behind. We're going to talk today to our audience, our patients. Uh, the people that get to see me are people that have SI joint dysfunction. We'll talk about that in the next session. But for now, the courses are open to interventional pain physicians, interventional spine surgeons, as well as licensed interventional radiologists. My goal here is to teach you best practice, the best way to approach the SI joint safely, effectively, and without complications. This PML technique is very safe. It's one incision, and it takes about 30 minutes to do both sides. As a freshman or someone that hasn't done SI fusion before, it may take a little longer. And you really don't need anything more than a fluoroscopy. If you have a CT navigation, it's also great because you get to do a spin and see a 3D image of your screws before you wake the patient up. So today we're just going to go briefly and talk about the innovation of the SI joint. The SI joint is the largest joint in the body, if you didn't know that. It connects your spine to your hips. So very, very important. It has two surfaces, the sacral surface and the iliac surface. It's the only joint in the body that has two different types of cartilage. The synovial cartilage is on the sacral side, and the fibrocartilage is on the iliac side. So those two cartilages actually interact, even though they are different type. Only joint in the body that has two different cartilages, so very unique. The anterior surface of the SI joint is innervated by the ventral rami from L5 through S2. And these are all coming off the lumbar plexus. And then the dorsal rami, which is the posterior aspect of the SI joint, is innervated by the dorsal, which is posterior, rami of S1 through S4. So this holes are all holes for the foramen, S1, S2, S3, S4, S5. So the dorsal rami of S1 through S4 supplies the dorsal aspect of the SI joint. So when you go to a pain physician or anesthesiologist that wants to burn your nerve, those nerves are these nerves here. So the dorsal rami nerves are the ones that typically are burnt for RFAs, radio frequency ablation, or a neurotomy. They are talking about these nerves here. And those nerves sometimes are covered by insurance. Medicare currently does not cover rhizotomy of the dorsal S1 through S4. They used to cover it. They stopped covering the January of this year. So patients have limited options. At this point, they do the injections. They can do up to 2 injections before the surgery. Now that the procedure is very quick and safe, it's outpatient. Uh, it's not uncommon to go from the injections to the minimally invasive SI joint fusion. So again, dorsal rami S1 through S4, ventral rami of L5 through S2. Again, ventral rami of L5 through S2, right there. So that is the innovation of the SI joint. There are some other nerves, like the cluneal nerves. These nerves supply the PSIS. So when you do another approach called the posterior lateral oblique approach for the SI joint, which we'll talk about someday, those nerves can be injured when you make your incision over the posterior superior iliac crest. So it's called the cluneal nerves. They are sensory nerves. So again, short knowledge drop this evening. I want to thank everybody for being supportive for our journey to educate our people, our patients, our surgeons about the SI joint, the safety uh, method and technique that you can use to stabilize the SI joint. We'll talk about the motion segment of the SI joint next time. We'll talk about the types of movement the SI joint has, as well as the angulation, the stress of the SI joint, who the SI joint dysfunction affects, what a chiropractor does. What's the role of a chiropractor in SI joint diagnosis? So enjoy this. Continue to follow us on the journey. This journey is going to be a nice, long journey, ups and downs. But we are focused, guys. We're going to get this done. Much love. Godspeed.